Imagine you're at an auction, but instead of bidding on antiques, vintage clothes, or even farm equipment, you're bidding on healthcare services. A company selling eating disorder care, for example, might hear bids from 25 different insurance plans in their state. Each plan offers up which services they'll pay for and how much they'll pay, with a goal of settling on an agreement that allows the treatment company to make a profit, while the insurance plan keeps their costs as low as possible. Now, let's say maybe 10 of those insurance plans get their bids taken. The other 15 would go back to the drawing board or go to bid on another facility that's willing to negotiate a lower payment. This is a very, very simplified analogy of how health insurance contracts work. Now, imagine you are a Medicaid or Medicare plan whose funds are limited due to the sheer volume of members and how much Congress allocated for your budget that year. As a publicly funded insurance, Medicaid and Medicare funds come from state and federal taxes, and payments to healthcare servicers are notoriously low. In the bid for an eating disorder care contract, Medicaid and Medicare will almost always lose out to commercial plans. Currently, Medicare does not cover any eating disorder services in any state. This is because of the Medical Nutrition Therapy Act, or MNT Act of 2000, which authorized Medicare servicers to only cover nutrition services for members with type 2 diabetes or severe kidney disease. There are a host of other nutrition-related diseases, such as type 1 diabetes, high blood pressure, malnutrition, prediabetes, heart disease, GI problems, and eating disorders, just to name a few, that are not currently covered. Medicaid is a little trickier as certain managed Medicaid plans can negotiate reimbursement contracts on a facility-by-facility basis. Today, I'll only be focusing on eating disorder coverage as this is where the greatest inequities lie. I will also be referring to Medicaid and Medicare together as there are many individuals who are enrolled in both plans, and Medicare policies often influence Medicaid policies and vice versa. The current state of Medicare and Medicaid coverage limits access to eating disorder care to only those with commercial insurance plans. So when thinking about who exactly this policy impacts, we have to think critically about who is most likely to be insured by Medicare and Medicaid. First off, a single person making less than $1,836 per month, or formally below 135% of the federal poverty line, which can be adjusted for a number of dependents, would qualify for Medicaid. So to say it bluntly, poor people are likely to be on Medicaid. Medicare, on the other hand, does not have an income guideline, but it does only charge premiums for individuals above age 65 whose adjusted income from the previous year is in the six figures. Disabled individuals are also eligible for Medicare and are also likely to be dual enrolled in Medicaid due to reliance on supplemental security income, or SSI, and certain limits placed on their earning potential to continue qualifying for disability-related services. The financial oppression of disabled individuals is a separate but very important conversation that we don't have time to dive into today. But it's very important to recognize this factor when analyzing any healthcare policy. Additionally, non-white individuals make up the majority of Medicaid recipients. So if you're poor, disabled, and/or a non-white individual with public insurance and an eating disorder, you will have an extremely hard time finding appropriate care. Now, the problem of eating disorder care access is often framed as just an insurance coverage problem. If facilities would just accept Medicaid and Medicare plans, if we could just pass a federal policy mandating Medicaid and Medicare coverage of eating disorders, then the inequity would disappear. It's true that the first step is making sure that insurance coverage is equitable among all plans, but the problem doesn't end there. Once insurance coverage is established, where will the individual go to receive care? Is there a wait list? How far away is the facility, and how will they get there? Is virtual programming available? Will the facility honor someone's cultural eating patterns, or are they just going to push a standard American way of eating? What if the individual doesn't speak English? Can they use an interpreter? And what about cisgender males who are often left out of the eating disorder care conversation and sometimes excluded from treatment? And what if someone can't take time off of work because they're poor, but they need intensive treatment for eating disorder care? How would they afford their other bills, even if treatment is fully covered? There are clear power dynamics at play with insurance companies, not medical providers, nor the individual seeking care, deciding which treatments someone needs. And money, not the need for care, being the key factor in negotiating both individual and plan-wide contracts with treatment facilities. And even with the hopefully upcoming passage of the MNT Act of 2025, it's up to Congress to decide what's worth covering, aka what's worth spending more money on. And we have advocacy groups who are challenging this power to make sure that patient and clinician voices are heard. Yet this power dynamic still exists. When the group deciding the fate of Medicare coverage of eating disorder care is one that by majority values profits and balanced budgets over people, advocacy must focus on establishing as many allies in Washington as possible to make sure they can use their power for good. Now, to illustrate this problem through an intersectional lens, I'd like to tell the story of my client, Sebastian. Sebastian is a 23-year-old white, disabled, transgender male with complex, severe mental illness and a below high school education. He came to see me, a dietitian at his community health clinic, to get help for his eating disorder. When I first met Sebastian, it was clear that he needed an intensive treatment program to help him recover from his eating disorder. But because Sebastian is insured by both Medicare and Medicaid, he was only eligible for services at one local facility in New York City. For context, there are only 2 facilities in the New York City area that treat adults and accept Medicaid insurance. Only one of those facilities accepts Medicare, and it's not even within the 5 boroughs. If Sebastian lived in any part of New York City besides Queens, he would qualify for transportation services due to his proximity to the facility, and he could receive treatment there. And if Sebastian had only Medicaid and not Medicare insurance, we could change his managed care provider so he could attend the other available facility. Because of his mental illnesses, Sebastian spends significant time in inpatient psychiatric care to keep him safe. While he's experiencing an intense episode of his mental illness, it's not appropriate for him to continue in eating disorder care due to prioritizing his immediate safety and well-being. Because Sebastian holds multiple oppressed identities and has experienced immense barriers to accessing eating disorder treatment, he qualified for a scholarship to a day program that usually only accepts private insurance plans. But since his eating disorder worsened so much in his time trying to find care, he first needed to be stabilized in the hospital before attending the program. If any one of Sebastian's marginalized identities were to be taken away, his entry and even access to care would be much smoother. But it's because of the combination of his identities, though, that he has been left to suffer the consequences of a system that wants to see him fail. At the heart of the systems impacting Sebastian is capitalism. The healthcare system in the U.S. is a for-profit model that relies on payments from insurance companies to stay afloat. Because some insurance companies pay more than others, and Medicaid and Medicare plans are at the bottom of their reimbursement rankings, commercial plans become more valuable than public ones. In starker terms, people with commercial insurance are more valuable patients than those with Medicaid and Medicare. We can also consider the influence of whiteness by investigating who exactly is in power in this situation. Congress is made up of mostly white males who will be voting on the MNT Act and other important healthcare policies. White men are also the leaders in many healthcare companies, and they are the ones with the power to decide whether treatment is covered or not. Speaking from my experience working as a dietitian in New York City, the only available treatment facility in these 5 boroughs that accepts Medicaid is in Manhattan, which has a nearly 50% white population. Arguments about space availability and patient proximity can all be traced to which lands are valuable and racist policies that have historically relegated poor, non-white individuals to the edges of Manhattan and the remaining 4 boroughs. As I mentioned earlier, disabled individuals have to follow specific income limits on their SSI and earned income in order to continue qualifying for services. Because of this ableist policy, if an individual earns or saves above a certain amount, they can lose their Medicare coverage and be faced with a future without health insurance. Medicare, though subpar in offering eating disorder care, helps provide for the often complex healthcare needs of disabled individuals. Just doesn't provide too much so that those individuals can remain disadvantaged. A key step in closing the eating disorder care gap for people with Medicaid and Medicare is to pass the MNT Act. While it by no means fixes the entire problem causing these disparities, it is a solution within our current system that can provide individuals with the care that they need. Ideally, the U.S. would transform the current healthcare system and enact a universal healthcare model that dismantles the current for-profit model in favor of equitable healthcare coverage for all. Until we get there, though, essential steps toward improved coverage of eating disorder care should include reallocations of the federal budget, such as from defense to healthcare, and taxes on the ultra-wealthy to fund budget gaps, or even that universal healthcare system I mentioned. Finally, I can imagine a world in which there are additional state and federal funds allocated to eating disorder treatment centers that accept a minimum number or percentage of clients who are insured with Medicaid or Medicare. So, with all this said, what can you do now? First, you can learn more about the MNT Act by going to the Academy of Nutrition and Dietetics website, www.eatrightpro.org/advocacy, and exploring their position statements, current initiatives, and calls to action. Second, you can get involved in advocacy. The Academy of Nutrition and Dietetics website has guides for contacting your representatives and urging them to support the MNT Act. If you'd like to take a more active position in advocacy, the Eating Disorders Coalition website, or www.eatingdisorderscoalition.org, has ways to get involved in pushing for transformative legislation to further reduce eating disorder care disparities. Thirdly, if you'd like to contribute financially, the Eating Disorders Coalition is a great cause to support, as is Project HEAL, which is the only national nonprofit to offer scholarships and cash assistance for eating disorder care. And finally, if you are an eating disorder care provider and are passionate about closing care gaps, consider offering any number of equity slots for people on Medicaid and Medicare in your state to receive your services. If you're unsure how to navigate equity or scholarship slots, becoming a treatment partner of Project HEAL is a great way to start.